Good afternoon. Well, I think we can go ahead and get started. And I know a couple people will still be hopping on, but I'll start the introductions here. So, welcome. My name is Renee Calkins. I'm the education manager here with the Michigan Center for Rural Health. And just a little bit about us, the Michigan Center for Rural Health is a nonprofit state office of rural health. And a cornerstone of our office is to provide free education for rural healthcare providers. I will be the facilitator for this program, and I would like to welcome everyone to today's Social Work Behavioral Health Series Grand Rounds. This program is providing one contact hour for social work. We are an approved provider with the Michigan Social Work Continuing Education Collaborative, and one contact hour for MCBAP for related 1 hour related work. Physicians can also self-claim this hour. And for completion material and financial disclosures, for successful completion, you just need to participate in this learning activity and the post-session evaluation. At the conclusion of the session, we will have a QR code and drop it in the chat box at the end of the session. There's no commercial support for our program, and no one with any relevant financial relationships have any disclosures. And today we would like you to learn that you have an increased knowledge in the biopsychosocial model, utilizing assessment tools and creating comprehensive assessment that ties in with other components of a client's treatment episode. And with that, I would like to introduce our presenter today, Jenny Grover. Jenny is a project associate with the Northern Michigan Opioid Response Consortium for the past year and a half. She graduated with a master's degree in social work from Spring Arbor University and has 6 years experience as a clinician and program administrator in the healthcare setting. Thank you so much, Jenny, for being here today, and we are very excited to kick off this series with you. I'm going to go ahead and stop sharing my screen so you can share yours.
All right. All right, can you see the presentation? All right, I will get started. Thank you everybody for taking time out of your busy day to join us. This is a 6-part webinar series that is designed to kind of walk a client through their treatment episode of care. So we're starting today talking about clinical assessments, and we'll talk a little bit at the end about the following ones. So we have a lot of information to cover today, so I'm just going to jump right in. But before we do, I just wanted to note that this webinar is a brief overview for clinicians in both the SUD and mental health space. And we want to make sure to include that you follow your agency's specific procedures for assessment. So take what fits into your situation. So agencies vary, and anything we might cover might not be applicable to your agency. And assessments are performed at all levels of care. So we have inpatient, PHP, IOP, outpatient. We also have clients in both the mental health and the SUD space. So compliance requirements do vary based on your client, their funding source, and where they're at. So therefore, some items that we cover, especially when we get to the compliance section, are going to be more general in nature and not specific. And then, of course, any questions that you might have throughout, just please note, and we're going to make time at the end for some Q&A, and you can drop it in the chat as well. So what is an assessment? What is the point of an assessment in behavioral health care? So essentially, we're collecting information on the client so that we can identify, analyze, evaluate, and ultimately address the client's problems in treatment. We're going to talk a lot more about identifying both the needs and the strengths of the client later on in the session. We also want to determine if a client is appropriate for services. So we're talking about medical necessity here. And that is what is going to get the client's services authorized and funded. Also determining what level of services does the client need while they're in treatment. Do they need case management? What kind of groups? How do we prepare for aftercare? Things like that. And it's important to note that an assessment is an ongoing process throughout treatment. So it's not one and done, never look at it again. So the assessment is one of the, if not the first face-to-face interaction that we're having with our clients. And it helps us to develop a rapport with the client. It's also going to guide the entire treatment planning process. And assessments should be revisited throughout treatment. Clients have situations that change, and we want to make sure that we're tailoring their treatment to their specific needs. So reassessing the client when appropriate, whether it be to evaluate if they're ready to step down to a lower level of care, or if you need to get the client reauthorized for services. And we want to make sure that if there is a previous assessment from another treatment provider, that we obtain a copy of that assessment if possible. And we want to document our attempts to do so. And so what is the difference between a screening and an assessment? So this is the definition from the Center for Substance Abuse Treatment that sums it up well. So screening is something that is more brief. It can be done by other staff, such as at intake. It can be done more widely. It's really just to identify if there are any areas in the client's life that we might need to further examine with an assessment. So we're evaluating for the possible presence of a problem, but we're not diagnosing or even determining the severity of a disorder. And so an assessment is more in-depth of an evaluation. It confirms that there is a problem. It's determining the severity. And we're also going to determine what treatment options there are available for addressing the problem. And we're also looking at strengths and resources that the client has available to them. So the biopsychosocial model of assessments, that's probably the most common assessment method in behavioral health care. And if you look at the word itself, biopsychosocial, you see that there's 3 words included in that. So we're assessing for biological, psychological, and social factors that contribute to a problem that the client is experiencing. So we're looking at everything. We're looking at medical, mental health histories, family and other relationships. We're looking at, do they have adequate housing? We're looking at if they have employment. And so one such example of a biopsychosocial assessment that some of you may be familiar with is the ASAM Continuum for Adult SUD Services. And that is a biopsychosocial assessment because we are covering their biological, psychological, and social factors that are contributing to their problem. And we're also, because it's SUD treatment, looking at all 6 dimensions of the ASAM criteria. We're utilizing assessment tools that are available and ultimately generating a report which would include a recommended level of care determination. So for this webinar, and because there are so many different areas in behavioral health, it wouldn't be possible to have time to talk about all of the various tools that are available to assess. So it is just important to note, though, that it is part of the assessment process. It is also something that can be used outside of the assessment process, such as at intake. And ultimately, using assessment tools can support your recommendations for care. So when you get to the end of your assessment, you've gathered all of those different factors that are available. You'll get to a section, it might say clinical impressions, and diagnoses, or it could say something else. But ultimately, this is your opportunity during the assessment process to kind of provide that summary in your clinical input. Some of the things that would be appropriate to put in this section would include just a brief summary of the evaluation. So keeping in mind that there's going to be somebody on the other end of the authorization process that's going to be reading your assessment. They probably have to read hundreds of assessments. And so just making sure that we have a concise summary of everything that we want them to know. We can also here note any observable behavior from the client during the evaluation. We can talk about stages of change, any level of insight or awareness that the client has into their problems, and also any discrepancies of information that is provided. So if you feel maybe that the client is not being forthright, if they can't recall certain information, or if they're exaggerating or even underreporting, you can note that in this section. And then we also want to make sure that we support our diagnosis that we're making, so we can use assessment tools and any other evidence that we've collected throughout the assessment. It's also important that we identify the strengths of the individual and any resources that they have available to them, and if applicable, as well as strengths of their family relationships. And then finally, we want to make sure that we kind of lay out all of the problems that we have identified and how we can address them in treatment. There's another section on most assessments where you will have the opportunity to put your recommendations for treatment. So you can include scores from an assessment tool as a support, and this will vary from agency to agency. Maybe some agencies put their scores in a different section. We also want to ask ourselves when we're making our recommendations, who will be reading this assessment and what information do they need to know? So if the client was referred in by the court system or CPS, maybe they want to see that we are recommending something to address that. And then also the funder, medical necessity, they want to know why you're recommending the treatment and what you are recommending. And we also want to make sure that our recommendations for treatment are carried over into the treatment plan. So if we're saying the client needs this, and this service, that we're addressing that in treatment and that there's not a disconnect there. We also want to make sure to revisit during the discharge planning process. So looking back at the recommendations that you made at the start of treatment in the assessment, which recommendations were you able to address? Those, there might be unresolved issues that are still present that you need to address in a lower level of care as a part of their aftercare. And so just making sure that you tie up all those loose ends during that process. And then making sure that your recommendations for care and what services you are recommending are justified throughout the body of the assessment. Next, we're going to talk about some ethical considerations that might come up when you are completing an assessment. And so what do you do if you are doing an assessment for the client and you find out, for example, they need IOP level of care, they're not appropriate for residential, but you have a probation officer or a judge that has ordered them to complete 90 days of residential treatment. So it's important to note that probation officers and judges, they might view treatment as a substitute for incarceration, and they may not have a full understanding of what medical necessity is. And unfortunately, for the client, probation officer or judge's recommendation or order of treatment doesn't constitute medical necessity. So there's a couple of things in this case that you can do. First, just being very familiar with what the medical necessity criteria are for your level of care that you're in, whether it be mental health or if you're in SUD treatment, it would be the ASAM criteria. Because there might be things that you wouldn't otherwise be aware of that really could advocate for your client to be able to stay longer to fulfill that requirement. However, you may really have a situation where you just don't feel that residential is appropriate, or maybe after 30 days, they're just not progressing any further, and it's clear that they need to take that next step. In that case, just making sure that you educate whoever the person from the court system is that you're communicating with. The client would love to stay here for that long, but unfortunately, this is what will get their stay covered, and they no longer meet the criteria, and here's why. Some treatment facilities have figured out kind of how to navigate this. They might have multiple levels of care with supportive housing, either on site or very close by. But if not, just making sure that we build a strong aftercare plan and try to figure out how to maybe step them down to a lower level of care, but justify elsewhere by regular attendance at meetings or transitional housings, how they're still going to have a certain level of structure. So the level of care recommended doesn't match the current need. There's a couple of ways this could happen. So we mentioned earlier the ASAM continuum assessment or other assessments might generate a recommended level of care based on the information that was entered into the assessment. And that's not always foolproof, and it's not taking every factor into consideration. And if that's the case, just making sure that when we're doing our clinical impressions and we're doing our recommended treatment, that we indicate why that level of care is not appropriate. Also, in behavioral health care, you might have clients that are admitted multiple times. So they've had a recent assessment either at your agency or at another agency. And if that's the case, it wouldn't be appropriate medically to complete an entirely new assessment. So just making sure, if that's the case, that we go through and we review everything from that assessment and know anything that is no longer applicable to the client. Maybe a few months ago, they were having supportive housing and they got kicked out and now they're sleeping in their car. So that's something that would definitely impact what level of care that they need and also what we focus on in aftercare. So just making sure that we know what level of care we believe that they do need and what level of care or what services that are more appropriate for the client. So our third ethical consideration is be aware of your audience. Who will be reading your assessment? So we might have clients that get referred in by, as I mentioned, CPS or the court system. And it might be part of the condition of their treatment that they share certain things from their treatment, such as the assessment. If that is the case, just knowing that we want to make sure that we're balancing the need to justify and highlight all of the issues. This is why they need treatment, but being mindful that we don't want to inadvertently harm their case with the court system or with CPS or whoever else that they may be dealing with on the outside. So when another clinician has completed your client's assessment, so in behavioral health care, this can be fairly common. So the simple fact of another clinician completing your client's assessment in itself is not really an ethical issue because this does happen. However, the ethical consideration really would be, what do you do with that previous assessment? making sure that we're doing our due diligence. So to start, we want to make sure that we get access to that if at all possible, because that's going to contain things that the client may not recall, or that would really kind of influence their level of care and their needs, and also kind of give you a better insight as their clinician as well. And so we also want to make sure that if they're coming in with another assessment, again, their situation is going to change constantly. So we want to make sure if there is a former assessment that we take the time to review that assessment. And if we notice anything that may no longer be applicable, just verifying that information. And finally, we have a client that is intoxicated or otherwise impaired when attempting to complete the assessment. Ideally, we would like to come back the next day when the client is in the right frame of mind, because they're not going to be able to give us accurate information if this is the case. So where this could be an ethical kind of issue would be if you have a funder, for example, that states the client must have an assessment within 24 hours of admission. And we could ask them, and maybe they would be willing to work with us if we explain. I won't get very accurate information from them right now, but if I could do it tomorrow, and they may be willing to work with us. If they're firm, no, we need an assessment within 24 hours of admission, just making sure that we note very clearly throughout the assessment that they're impaired or intoxicated, and that the information that they may be providing might not be everything. And that way, later on in treatment, if you obtain additional information from the client that would impact their treatment plan and add goals to it, and or change the focus of it, we have that in the assessment that we got this information afterwards, and here's why. So next we're going to talk about compliance and reimbursement. But before we do that, it's important to note, like, why is compliance and reimbursement so important as clinicians to understand? And we need to understand that there are going to be different entities that have an interest in reading your assessment, and they're looking for different things, and they have different requirements. So if you have a client in Michigan, they have Medicaid, or possibly they have no income, so they get Black grant funding, whatever the case may be, you might be dealing with a prepaid inpatient health plan, also known as a PIHP. So there are 10 different PIHPs in the state of Michigan that are listed here. And depending on where your client resides is the entity that you would be dealing with. And at each of these PIHPs, there's going to be individuals such as care managers that are charged with reading the documentation and making sure that before they authorize services, that they make sure there's medical necessity present. They also probably are dealing with hundreds of different things that they have to go through. And so making sure that we're aware they don't have time a lot of the time to read an entire assessment. So really kind of making the most of the last part of the assessment where we can provide our impressions and recommendations. We also have internal agency compliance departments at some agencies. It could also be that there's utilization review or even billing staff. Maybe if it's a smaller agency, the billing staff need to review any of the documentation that they submit for reimbursement to make sure that it's meeting certain criteria. We also have our commercial insurance payers, such as Blue Cross, Blue Shield, or Aetna. As well as different accreditation organizations, such as the Joint Commission or CARF, depending on what agency you work for. They're not going to sit there and read every single assessment, but when they come in and do audits, they do ask for samples of client documentations, and your assessment may be one of the things that gets pulled. There's also the future providers that you will be sharing your assessment with. There could be other stakeholders involved, such as CPS or probation officers. And in some cases, the client, if they submit a records request. So with that, there are people that have a vested interest in reading the assessment and determining if they are going to authorize services. And there's certain requirements that are more common that we'll talk about today. We won't get into too specifics just because they are going to be so different. But one of the ones is making sure that identified strengths, so their resources and then their needs, their issues and problems that bring them into treatment. We want to make sure that those are carried over into the treatment plan. We also want to make sure that the assessment is conducted within the required time of beginning treatment. So that could vary. It could be within 24 hours. It could be within 3 days. It could be within 14 days. It's going to be different, but we just want to make sure that we complete that in the required time period, because by not doing so, that could jeopardize their entire authorization. One of the most important things is making sure that we are demonstrating their medical necessity for services. And diagnosis code should be covered by the funder. There might be instances where, just a quick example. So if somebody is in detox treatment, we know that opioid use disorder, severe with withdrawal symptoms, is going to get them authorized for services. But if they present to treatment and they have inhalant use disorder, for example, and they're not really quite ready for residential, that might be something that has to get navigated. Demonstrating coordination of care with other providers. So we mentioned earlier that it's important to obtain a copy of their previous assessment, but also when we are transitioning them to the next level of care, we want to make sure that we're also sharing their information. And by demonstrating coordination of care, that really, we want to make sure there's evidence in their chart that we're doing that. And it could be that the client doesn't want you to share their assessment with anybody. And if they don't have to, if there's nobody that requires that, that's completely fine. However, we could put a note in their chart that we asked the client and they refused. And then finally, we want to make sure that we are ensuring a release of information has been obtained before sharing the assessment with anyone. And not only making sure that there's a release of information in their file, but also taking the time to open that release of information and checking that release doesn't prohibit you from sharing that. They may have a release where they only permit you to share their drug testing screens. So making sure that we have that in place is going to be something that when an audit comes around, it's going to be checked. So we also want to make sure that assessments are signed by the clinician who completes them with the supervisor's signature present when applicable. And that might seem like something that is common sense, but some of the assessment tools that are out there are electronic. And so this does happen where the clinician will complete it and then not add their electronic signature. And then also if you require a supervisor signature, that they have a chance to review the assessment and then add their signature to that. Only signing assessments that you have completed yourself. So if an agency were, say, understaffed and somebody that was not credentialed to complete assessments, filled in all of the information, that would not be something compliant for us to sign off on. And assessors should be trained in providing assessments. So if you're new to the organization and you've never completed an assessment before, making sure that you have the opportunity to sit in on a few assessments, or some specific assessments, such as the GAIN assessment or the ASAM continuum, might have further requirements that you take to get credentialed to be able to administer those. We also want to document clearly if the assessment was not completed face-to-face. And this is something that a few years ago, we definitely saw more of. And it could be the case that telehealth services are completely acceptable and billable, and that's fine. We just want to make sure that if it was not completed face-to-face, that we include that in the assessment, and we include how the assessment was administered. So some of the tips to consider when you are completing your assessment. So a strong assessment is concise. It's not overly wordy. Again, there are going to be individuals, particularly funders, that are probably going to skip over right to the end of your assessment because they just don't have the time. And we don't want fluff words to kind of drown out the case that we're trying to make. So the more simple that we can be, the better. We also want to avoid the issue of overstating the client's strengths and understating the issue. So it can be tempting to talk about all of the great attributes of the client, how motivated they are, and it's important to include that. But we don't want to do so to the point where we're overstating it and then we're not highlighting the issues the same way, because the funder is going to look at that and say, okay, well, they are doing so wonderful that it looks like they don't need treatment. And that is something that has happened to me before. On the other side of that, you want to avoid overstating the client's issues and understating their strengths. So we want to make sure we're justifying medical necessity and including all of the things that are going on with the client, but not to the extent where we're not also focusing on their strengths. And the funder is going to look at that and think, okay, well, they have all of these issues. They don't want to be there. They're not motivated. So it looks like they're not going to benefit from treatment. And especially with commercial payers, this is something that I have encountered. So just remember, words matter. Most importantly, we always want to include factual information in our assessment, but the way that we present that information is very important. And so one of the ways that you can kind of balance the need to highlight their strengths and highlight their needs is called however statements. So I'll give you an example. You could say the client has very poor coping skills and a lack of impulse control. However, the client shows a clear motivation for wanting to be in treatment. Therefore, the client could benefit from being in a highly structured setting at the residential level of care. So we're just making sure, if we think about it in terms of that we're highlighting both strengths and the problems. So when we talk about documentation in treatment, you may or may not have heard of a term called the golden thread. So what is the golden thread? So the Oxford Dictionary defines the golden thread as an idea or a feature that is present in all parts of something. It holds it together and it gives it value. So how does that translate into behavioral health care? That concept is really applied to the documentation of a client's complete episode of care. So we're talking about the assessment, the treatment plan, the discharge plan, and then any group or therapy notes. It's all interrelated to each other. And this is not only something that is important for compliance and reimbursement, but also just for delivering high quality care to the client. If we identify a problem in the assessment, we want to carry that through their entire treatment episode. And so tying the assessment to the treatment plan and to the discharge plan. So there are multiple different entities and agencies that you might be from, and they're all going to have different rules and regulations. But this is one that is pretty common throughout everything. So I just pulled one example, and this is called Treatment Policy 10. And there's a link for that there. And Treatment Policy 10 was developed by the state of Michigan to have rules and regulations for residential substance use treatment. And so in that policy, it states, treatment planning requires an understanding that each client is unique and each treatment plan must be developed based on the individual needs, goals, desires, and strengths of each client. And this part's the point I'm highlighting, and be specific to the diagnostic impression and the assessment. So we don't want to have an assessment where we identify all of these issues and then have a treatment plan that's completely unrelated to the assessment that's addressing entirely different issues. It might be possible later on in treatment as they progress that you do identify things later, and that's fine. But we don't want to leave things unaddressed. And so what that translates to is matching goals to needs. So we identified needs on the assessment, and we want to make sure that we are reflecting those needs in the goals on the treatment plan. If it is something that you have identified that you can actually achieve in treatment. So discharge planning is the same concept. There's going to be specific rules and regulations about discharge planning. And that is also interrelated and part of the golden thread in treatment. So when you are doing your assessment and you are kind of coming up with your problem list, you want to ask yourself, what issues can be reasonably achieved in treatment? Those are the things that we are going to include in the treatment plan. And then at the end of treatment, making sure if that didn't get addressed, maybe you didn't have time for whatever the reason may be, just tying up those loose ends and maybe recommending that to the next level of care. We also want to note which issues will need to be deferred until after treatment. So you might have an agency where you have a dedicated case manager, and discharge planning and finding housing is a big part of the program, and that's great. That is something that they can work with while the client is in treatment. But you also might work for an agency where that's just not possible if they have a shorter length of stay and you just don't have the ability to address other issues such as their housing, or perhaps they could use marriage counseling, but it just wouldn't be feasible for that to happen while they're in treatment. So we still want to make sure that they're identified in the assessment, but those are the things that you're going to find maybe as recommendations in the discharge plan. And then we also have further behavioral health webinars this year. So as I mentioned, this is just part one. In April, we're going to be diving into, this is specific to those in SUD treatment. the ASAM medical necessity criteria. In June, we'll be talking about treatment planning and diving kind of in depth into that and how it relates to the golden thread. We're going to be talking about all of the documentation that we would encounter during a treatment episode in August. And then crisis planning and intervention in October. And then finally, we're going to be talking about discharge planning in December. And so we are still in the process of kind of pulling all of that information together. And we want to make sure that anything that we are covering is relevant to you and your organization. Is if you have suggestions for upcoming trainings, Renee will share the link for that evaluation, but please complete the questionnaire. Even if you don't need CEUs for this training, you can still complete it. And there's going to be a spot in there. And you can note any of these topics that you see that you're wondering something about, and we can make sure that we include that in one of those trainings. There's a QR code up here on your screen where you can register for our April training. It'll be on April 9th. And then if you complete the questionnaire and you have any suggestions later, or you think of questions later, please feel free to email me at any time. So I included that on this as well. So with that, I'm going to open it up to any questions that you might have.
Thank you, Jenny. Please feel free to either unmute yourself or type it in the chat and I can read it off if you have any certain questions. We can also use this opportunity to see how things are going in your, just to have, maybe some comments on how assessments are going in your facility as well, just to get a discussion between providers as well.
Renee, I just wanted to note real quick, my laptop is about to die, so I'm going to go really quick, run and grab my charger.
Perfect.
I'll be right back.
Just wait a moment. Please feel free to be ready to come off mute or type it in the chat. All right, we did have a kind of a question here. Since the assessment may not be read completely, should the recommendations be at the beginning of the assessment rather than the end?
Not necessarily. I know when I was dealing with the different commercial insurance payers and the PIHPs, they told me we just skip to the end, so they'll know where to find that information. So I would say that in most cases is going to be where they skip to, but I don't think it matters if it's at the beginning or at the end.
And then we just had a comment saying absolutely agree that words matter, so it's important. That's a very good reminder. Any suggestions on how to get more information from clients who present guarded or give little information? It's a great question.
I would say, of course, obviously we can't make them tell anything. However, just having a good rapport with the client, but also letting them know. I found when I was doing assessments with clients and they wouldn't give me much of an answer, just letting them know, well, I'm trying to get as much information as I can on your situation so that, you know, like we can get your services authorized. You do need to meet medical necessity criteria for services. And that did prompt more forthright answers. And then also later on in treatment, they might open up more and you can adjust their treatment plan and just note the new information in their chart.
Any other questions? If you guys are thinking about it, what I will do is go ahead and share my screen with the QR code for the evaluation, as well as I will drop it in the chat box here. But please feel free to keep asking questions in the chat or come off of mute and just state who's speaking so we know. So grab it and put it in the chat.
And I did want to note too, when we do the ASAM medical necessity criteria, I know that this, the flyer says for clinicians or counselors. However, there might be other staff in your agency that could benefit from knowing what the criteria are and kind of how to use that to advocate for the client. It could be a case manager or even maybe a billing staff. If you feel that it would be beneficial to them, we'd love to have them join us as well.
Yes, and please, as Jenny noted, please have any comments and suggestions so we can make this series as best as possible. Well, I will give you guys a few more minutes with the QR code up on the screen, and then we can just utilize this time to say thank you very much for attending today. We appreciate your attendance. It's so great to see all the turnout, and we look forward to the year with you guys.
Yes, thank you so much for joining us, and hopefully we'll see you again at the next one.
Yes, and thank you, Jenny, for being here today. We truly appreciate your time.